Thanks for coming. My name is Scott Fishman. I'm a professor here in the School of Medicine, and we're going to get started. Everybody good to get started? Everybody? Hello? Yeah. So, are you guys mostly med students? And what year are you? Are you're second? Second? Are you guys second years in the med school? So everybody's from your fourth year. Great. And first, okay. So we've got a little bit of a smattering. So these are the luncheon words. I'm not sure how many of you have been to some of the previous ones that we've held, but you've heard me then say that this is really about focusing on your scope of practice as clinicians. I'm a pain specialist. I'm a professor of anesthesiology and pain medicine, but I'm also the executive director of a wellness office that's putting on this meeting. It's actually not the wellness group that helps you with student burnout and other wellness areas, but our issue is really expanding the scope of what you do as clinicians. And we've tried to bring you examples of clinicians who are really in this space of addressing prevention and lifestyle as it affects what people eat, how they move, how they think, because we have very good data that those things affect your propensity for illness, their resilience if they do get illness, and reducing chronic illness that comes on and becomes the kind of the scourge of the economic culture. So our hope is that we can expand our focus as a health system to not just be a disease response system. And obviously, you as students, we need to train you not just to be disease responders, but to truly be health professionals, which means that you look at that full scope. So today, we have a great speaker for you, Dr. Cam Hostinar, who's a tenured faculty member in the, is it Letters and Sciences?
In the psychology department. Yes, in the College of Letters and Science, yep.
So she's a psychologist who has focused on this issue of social connectivity. She focuses on developmental issues for people, not a physician, but she's going to be talking to you about a really important area that we tend to forget about, which is the impact on health of social connectivity. And she's going to be talking a little bit about the Surgeon General calling this out recently. That we have an epidemic of loneliness, isolation, and it probably even goes to this propensity that we have in America of people seeking ways to dissociate, like chemicals. So I'm not going to preempt Dr. Hostinar's talk, but I want to welcome her. Thank you for coming.
Sure.
Without further ado, I'll turn it over to Dr. Hostinar.
Thank you so much. Let's see, let's turn the mic on. Thank you so much, Dr. Fishman, for the lovely introduction. I am Cam Hostinar, Associate Professor of Psychology here at UC Davis. I'm very excited to be with you today because Grey's Anatomy is my favorite show, so I'm really excited to be in a room with real live medical students. Very exciting. And today I want to talk to you about the importance of social relationships for health, and how, even though we are on different sides of the UC Davis campus in psychology or the med school, we actually have a lot in common in terms of wanting to promote physical and mental well-being in people. And as evidence of this, as Dr. Fishman mentioned, the U.S. Surgeon General made it a priority to really emphasize the increased prevalence of loneliness and isolation as an urgent public health concern in 2023 through this health advisory, where he and other experts have reviewed all the evidence that links social connection and social disconnection to various health outcomes. From mental health outcomes like depression, suicidality, to even physical health outcomes like infectious diseases, diabetes, and so on. And what this evidence indicates is that people who experience loneliness and social isolation also tend to have poorer health outcomes. And you can imagine an adolescent who is diabetic, who is really struggling with loneliness and isolation, who's maybe not following his medication regimen and is really suffering physical consequences as a result of his psychological state. And to convince you of this kind of link between social relationships and mortality, I want to show you just a bit of data from a meta-analysis done by a social psychologist by the name of Julianne Holt-Lundstad. She and her colleagues reviewed a lot of studies that link the quality of social relationships to mortality. And what this chart is showing you is the effect size for the link between social relationships and mortality overall. This is showing you odds ratios. So 0.5 would correspond to an odds ratio of 1.5. Over there, they're plotting, and then you could see the overall finding from this meta-analysis was that you see about 0.4 a link there between social relationships and mortality as an overall finding. It goes a little bit higher when you look at more complex measures of social integration. And then the creative thing that they did in this paper was they compared this effect size to effect sizes published in other papers that link alcohol consumption, physical activity, BMI, air pollution to mortality, to see when we compare these effect sizes, which one would be larger if we plotted them on the same side. And you can see that the strength of the association for the link between social relationships and mortality is comparable or higher than links between other health behaviors and mortality. And this is really interesting, but it begs the question whether this association is causal, and also what are the mechanisms that link social relationships to mortality? How does this occur? And in the Surgeon General's health advisory, they go through a number of pathways: biological pathways, psychological pathways, health behavior pathways, things like smoking, alcohol consumption, and physical activity, and so on. But one mechanism I'd like to focus on today, because this is some of my own research and I know a lot more about it, is research on stress buffering, or that happens with the presence or assistance of a social partners. In other words, social relationships can lower our stress, and we all know that chronic stress has been linked to a lot of health outcomes. So that's one potential pathway. I have an example from my own family of social buffering. This is my daughter when she was 1. Terrified of Santa, send my husband in there, and she was instantly calmed. These pictures were taken 1 second apart, so this is pretty instant that you see this social buffering effect. And I did not include a picture from this past December where they're both happy, both my daughters are happy taking a picture with Santa. There's no long-term trauma here, just letting you know. But this exemplifies what I'm talking about here, which is that it seems to be that the presence or assistance or of a social partner seems to block or lower the stress response and give us a sense that we can cope with stress a little bit better. And to show you data from my own work about how some of this social buffering might unfold in real life. In this study, we recruited 9 and 10-year-old children, showed on the left-hand side, and 15, 16-year-old adolescents, shown on the right side. We brought them to the lab. We exposed them to a laboratory stressor that's a public speaking task. Turns out public speaking increases activates the stress response, increases your heart rate, it leads to the release of cortisol from the HPA axis. We know public speaking is a very reliable, robust stressor that we can use in the lab with children and adolescents. So we asked them to give a speech in front of judges and a camera. We measured their cortisol response through saliva samples. Saliva samples were taken every 20 minutes after the stressor. what's being plotted here, you see cortisol concentrations in saliva. And we also did something else. We randomly assigned kids to receive social support or emotional support from their parent before the stressor, or to be with a stranger, the experimenter, either me or my colleague Anna. And so you can see in red the parent support condition, and in blue the stranger support condition that kids were randomly assigned to, and adolescents were randomly assigned to. So what you can see here is that for younger 9-10-year-old children, if they were randomly assigned to receive parent support before the stressor, their cortisol stress response was blocked and muted. They didn't increase as much. For kids who prepared with a stranger, they didn't see the same benefits or the same stress reduction in terms of their cortisol response and what we can measure here in blue. So in blue for 9-10-year-old children, you see pretty much what we would expect, a robust increase in cortisol in response to the stressor. As we well know, adolescents start to build their independence from parents, and they tend to rely on friends and peers and siblings more for support. So we didn't see this effect in the older 15, 16-year-old adolescents. This isn't the only paper out there like this. There are many papers like this in the literature, some with adults and their romantic partner as a source of support. There are also a lot of animal studies that show social buffering effects like this in other primates, in rodents, and even in sheep and cows. When they're with their conspecifics or they're together, they seem to have a lower, more muted stress response than when they are alone or with an unfriendly companion or a stranger. So this is a paper where we reviewed a lot of evidence that stress buffering or the lowering of stress responses with the help of conspecifics happens across a variety of species. And this gives us kind of a mechanism for how you might get from positive social relationships to lower stress to better health outcomes in the long run if you accumulate these effects across the lifespan and across many different instances. It's not the only finding. It turns out that pets can also serve as a source of social support and can lower the stress response. I always get a question about whether dogs and cats can lower people's stress response as well, and they do, and they can. They can lower blood pressure responses to stress and other kinds of stress responses. So this has been well documented with pets as well as with human companions. And so if social relationships are so comforting and they reduce our stress response, why are more people not taking advantage of social support? Why do we have such a high prevalence of loneliness in the United States and across the globe? I want to take a minute to just define loneliness as psychologists define it, which is a discrepancy between desired and achieved levels of social relations. And this is somewhat different from social isolation, which is a more objective measure of being alone or time spent alone or not having objectively speaking, not having a large number of social relationships. The reason we make that distinction is because people can feel lonely even when they're surrounded by others. And we see children and adolescents sometimes report that they're lonely when they're at school, even though they're surrounded by many, many peers and teachers. And so loneliness is this subjective feeling of distress that exists that's a little bit different from isolation. But there are many causes for this. 30% more people live alone now than in the 80s. People delay marriage. There's social media and changes with technology that lead to people spending more time online and less time in person. There are many, many, many factors we could talk about that may contribute to this. But the fact remains that loneliness has become increasingly prevalent in the United States and in other parts of the world. There was a national survey done by Cigna, the health insurance company, where they found that half of U.S. adults endorse loneliness on their survey, and that the prevalence seems to be even higher for younger generations. So here, I'm not sure if you can see, but nearly 8 in 10 Gen Zers have elevated reports of loneliness, and 7 in 10 millennials versus about half of boomers. So you can see that in this national survey that's of 10,000 adults, US adults, there are very high reports of loneliness. And so we have this paradox in front of us. On the one hand, social relationships are very beneficial for our mental health, our physical health. But on the other hand, very few people are taking advantage of those benefits. And so we need to think creatively about how to maybe conduct psychoeducation to inform people of the benefits of social support, or conduct other kinds of interventions that would lower the prevalence of loneliness. And so I wanted to also chat together about this recent trend in other countries. It's slowly making its way to the United States, of the idea of social prescribing, which has been put forth by the World Health Organization, other health organizations like the NHS in England, and there are various organizations in Canada and Australia and other countries that have put forth the idea of non-medical prescribing, that is social prescribing, or connecting patients with community-based resources that will address some of the social determinants of health. So they would address things like loneliness, would help them be more socially connected, would help them be healthier, help support their mental well-being, help them be more active, give them support with their finances and financial literacy, help them in a wide variety of ways through social prescribing. So you would connect people with nonprofits or other kind of social services. I saw a recent report from Massachusetts where they attempted a social prescribing program where patients were prescribed to go to an art museum, and because it's prescribed to them, it would be free. So they could just go and do this enriching activity. These are some of the ideas out there, but you might have other ideas of how we can creatively address this issue of loneliness, the epidemic of loneliness, and how we might connect people with social supports in their community. So I want to have sort of an open-ended discussion with you all in just a few minutes. Before I do, here's my lab over in Davis, the Social Environment and Stress Lab with my students. We're a very socially supportive bunch. Feel free to reach out, email me, or check out our website if you have any questions about stress research or stress and social relationships. Happy to chat. And that's sort of what I prepared for today, but I'd love to chat with you and hear some of your own thoughts about the role of social relationships in medical care. Is this something that should be within the purview of physicians, or is this something that should be maybe relegated to the realm of psychology and school counseling? What do you all think about these ideas about social prescribing?
I love it. I think it's very easy to kind of incorporate. Oh, right, thank you. I love it. It's kind of easy to incorporate it to what we're already doing. Like if we're in the clinic and we're talking with the patient and recommending more exercise, it's easy to say like, here's a voucher to one of the, I don't know, the sport, like what are the names of the different things that exist already with the so those types of things. So that, costs wouldn't hinder them from joining, and I think prescribing alone, like that word kind of, it compels, or patients feel compelled to act on it, I think a little more than they would if it was just like, oh, I recommend you walk, 5 times a week type of thing, but like, here's a prescription for this, would be more compelling.
Yeah, I think social support is like a component of the social determinants of health that's sort of like glossed over. But I remember doing some work at Children's Hospital. We were looking at the impact of social support on like suicidality, doing party violence, and food insecurity, and it had really remarkable outcomes. And I think that it would be helpful, specifically within the world of medicine. Everything is like data driven, so having more research around social support and what that entails in terms of patients and their overall healthcare outcomes would be great. Something I'm like very much interested in because relationships are really all around us. Something we don't really think about too much. So yeah.
Yes, and I know for, since you mentioned working in the Children's Hospital, I know there's a movement now in California to screen for ACEs, adverse childhood experiences, so abuse, neglect, and so on, which could lead to some of these outcomes like loneliness. And so I think it would be interesting to see how many of these children that have an elevated number of ACEs also report feeling lonely. Are we talking about the same individuals? It'd be interesting to just add a question in there and ask if they're feeling lonely when we collect these data about adverse childhood experiences. So, and you're right that this matters tremendously. It matters across the lifespan, but for children in particular, they don't necessarily get to choose their social networks as much as adults, right? They live in this family environment that is better or worse. And so they perhaps need more supports. But yes, I love your comment. Thank you. Any other? Yes.
Yeah, I also think at the same time it's not quite as simple as like giving like a vector or whatever for a or museum or just saying like, okay, well, like go out, do something interactive. I think we need to really consider the in addition to that, like the depth of social connectedness, which really gets at like the root of that social isolation versus loneliness aspect of things, and really understand that the variety of depths of social relationships is important as well. And so it just makes me think about like when we're talking to patients, when we're asking, okay, who are you connected to? What is like assessing also like how open do you feel with them? And I think this comes up in conversations, especially around mental health, but also thinking about this being as like a general practice sort of conversation around whenever we're checking in with patients, especially if you're like in family bed or you're in inpatient setting, like checking in and assessing like the depth of those relationships. And from what like I've understood in like talking with patients and from personal experiences, that a lot of that loneliness aspect of things can come from feeling like this, that you have to withhold some part of yourself or some identity or some struggle that you're dealing with, which also sort of intersects with a lot of broader themes of like racism and different cultural differences and toxic masculinity and whatnot. And so I think there's a lot more to it than, unfortunately, than just being able to provide like a museum, like a ticket to a museum. And so thinking about like, how do we meaningfully engage with those conversations around having patients, like helping patients finding ways and opportunities to develop those deeper, more meaningful connections. I think that's a much more challenging conversation and not something that is necessarily like one size fits all either.
Yes, there's so much there I could react to. I mean, you are correct that there's a stigma against loneliness, so people may not feel comfortable discussing their feelings of loneliness with a provider or with anyone in their family. There's stigma associated with other identities that makes it difficult for people to disclose their identities, makes them feel alone. You're right that there are deeper issues related to loneliness and different causes for loneliness in different people. And so we conducted a recent review of the literature where we found a number of different pathways or different risk factors for loneliness, and one of it is personality, right? So shyness, social anxiety, behavioral inhibition, these kinds of traits can make it difficult for people to have more satisfying social relationships. And it's not easy to change someone's personality, right? So you're right that this is sort of a deeper issue. When we're talking about adolescents, they have an increased emotional reactivity and stress reactivity that comes online with puberty. And so when they're in that fight or flight mode, they can withdraw socially, they can start conflict. They may not necessarily know how not to alienate people in that developmental period. So there are these deeper causes that need to be addressed. That being said, there are a number of interventions that have shown a lot of success with reducing social anxiety and teaching shy kids social skills. We have randomized controlled trials that work, that show that we can make progress on some of these issues. And, with psychoeducation, we could teach adolescents about the stress response and the fight or flight response and why they might behave in ways that alienate people. You're right about toxic masculinity. As we saw in the Cigna study, there was slightly higher prevalence for adult males of loneliness compared to adult females. The gender differences bounce around a lot in the literature, but it is interesting that maybe that culture of toxic masculinity culture is contributing to this. So you're right that there's not going to be a one-size-fits-all solution, and it's not going to be as easy as giving people a voucher to a support group. But with different interventions happening at the same time, I think something could be done. And I think something that might be helpful to think about is the relationship between a provider and a patient as a potential alliance that could fight against loneliness as well. I know in the clinical psychology literature, one of the best predictors of success in therapy is what's called therapeutic alliance between the provider and the patient. And so the extent to which the patient feels that you have someone who's on the same page, who's in your corner, who's fighting for you to get better, could in and of itself lead to reduced feelings of loneliness. But I know it's difficult with 15-minute appointments to really make that connection with a provider who has many other duties too. So yes, there's so much there I wanted to react to. Very, very good ideas. Yes.
Hello. I guess I wanted to add that I agree that social prescribing is a really good idea. In general, I think it can help with, getting, once you get to know the patient, it can help with outside of loneliness as well. But I feel like for loneliness, as Prachi was mentioning and you were saying, that it can be really helpful for physicians to just kind of have the idea to look out for loneliness on their radar, because then it is like a much more complicated conversation of like, oh, okay, let me explore, like, is this like affecting them and how is this affecting them in that conversation, and then how you can help, which may be vouchers and will probably be very varied. I was also curious, you mentioned some causes of loneliness. I'm wondering, because it seems to be, such a huge scale problem, have you seen, what people are saying is number one, number two, top causes of it not just being individuals? It seems like it's something, it's an epidemic that's happened to a lot of people, which would seem like it's a social structure. I was not sure. I know you mentioned some, but I'm just curious.
Yes.
That stand out.
And I have to mention a caveat that, a lot of this literature is correlational, right? So it correlates personality with loneliness, or it correlates conflict in the family with loneliness. So we are struggling to figure out causally sort of what the main root causes are. But I think we've learned a lot from the pandemic, where we've seen sort of increases in loneliness in some populations, but not others. And so with these kinds of natural experiments, I think we've learned a lot about the fact that there's both structural factors, right? Such as people being physically socially isolated from others and not having the opportunity to meet others. But there are also pre-existing characteristics that people have that made them more vulnerable to loneliness during COVID and in general. A personality traits like neuroticism, which is a personality trait that makes people more prone to having a negative outlook and be prone to depression and anxiety. This can make them more vulnerable to loneliness. And so it's a combination of individual factors and structural factors and societal factors. And social media and technology plays into this as well. I will say there are also contextual factors. So if you think about college students being in their first year in college, they've moved away from all their family and friends. They're in a new group of people. They haven't yet built social relationships. You can imagine, and you as some of you are first year, second year med students, you can imagine that it's a context specific risk for loneliness. And then some people recover from that and they build relationships. So I don't know that I can answer the question of what's the number one or number two cause of loneliness. I suspect it would be different for different people. For some people, we talked about adverse childhood experiences and child maltreatment. It would be sort of a difficulty trusting people because their relationships have been so negative that it's worth not having them at all. So that's a different cause than a child who's shy and socially anxious and needs to learn social skills to get over that. And it's different from a first-year med school student who's lonely because they haven't yet built a social network, but they'll get there. And that's going to be different from somebody who spends 4 hours a day on Instagram and feels like they see a lot of people, but they're not having meaningful, deep conversations with these people. So they're lonely because they're not having the right kinds of social interactions. So yeah, I don't know. We need more research to address your question, but it's a very good question. Yes?
I thought it was interesting when you were to get a balcony for us. I thought it was interesting that you brought up like location, and because that's something that I think about a lot is the lack of public transit and walkable communities or like shared public spaces that are not about consumption. Because I feel like in suburban America in particular, I think even if we live densely, we don't live in a way that kind of facilitates like these random interactions that like then you get like the jokes about when someone talks to the cashier for a really long time in front of you. It's like that's regular social interaction that can actually really change like someone's perspective of like loneliness or like the amount of social this activity that you get in a day can kind of just come from little things like that and approachable public spaces. But then you also mentioned college, which I thought was really interesting because I think a lot of people look back on college as like a really fun, nostalgic time. And that's also a time that you're in a microcosm of like a walkable community with structured social activities that encourage you to like meet new people. And I feel like things like that can exist for like past college, but there's so much associated with like school and like childhood that there isn't really. I find like I kind of wish that there was like things that were as socially like open and structured, not structured, but like accessible as they were in college for people past that. So yeah.
Yes, that's a great idea. And, Dr. Fishman and I were talking about blue zones and how these hotspots of longevity across the world all seem to have many things in common, but one of them is that they facilitate social connection. They have a lot of community events and activities and dances and intergenerational living where a lot of people live with a very large number of people from their extended family. And so they have kind of built in social connection. And I think you're right that we need to think creatively about how we can engineer society so that we continue to promote social connection in adulthood as well, right? My daughter gets invited to like 25 birthday parties for every single kid in her class at the age of 6. I don't get invited to 25 birthday parties, so I'd like to be up there in terms of social popularity. And it'd be nice if we continue to have a lot of opportunities for social interaction, the way we do for little kids with adults. Right, and walkable communities, like you said, and shared community spaces would be part of that solution, and kind of re-engineering the public spaces. Very good food for thought. Other thoughts about these ideas, or is anyone skeptical or thinking like this is not going to work, or this is just we have already too much on our plates? No one's skeptical? Yes, go ahead.
Not so much skeptical. I feel like this is like really amazing research. I think about maybe some of those people who are like their obstacles, maybe like financial and like time-wise, like the mother who works 15 hours a day and gets back to her kids and doesn't have maybe those means. But then I can also see the argument of if there's more connections, as we've been calling it, then maybe there's more support, maybe there's more opportunities out there to kind of resolve some of those.
Yes.
So it's I agree, it's the causal relation, you can't really build anything out of that because it's so two ways or bidirectional, I guess.
Yes, no, that's a great point. And they do talk about, in the Surgeon General's report, they do talk about social capital and the benefits that you get from relationships that are not beyond the emotional benefits. You might also get benefits in terms of hearing about a better job or having help someone, someone could help you put together a CV and so on. But I think you're right that, in the Cigna study, they did find that those who had higher income were less lonely than those who had lower incomes. And it was a 7-point difference, which is very large for a national kind of survey. At the population level, this would be a pretty big difference. So how do we solve these issues? I think your insight is right on point here. There's a lot of literature in developmental psychology that shows that social support can buffer against the stress of poverty in both adults and children. And so it's not necessarily the case that if you're confronting economic hardship, you're going to be incapable of social connection. And you're right that, in fact, it protects people against those hardships if they have supportive family members and supportive friends. And they might even be able to problem solve and cope with some of those financial challenges a little bit better. And yeah, there's something called instrumental support, where somebody loans you money or gives you a ride to the airport, where you could see how that would alleviate some of the financial stress if you have a big network of people who can, do some of these, provide some of this instrumental support. So it seems like it's kind of a win-win. Social support seems like a win-win situation for everybody. But lack of time is the other thing you mentioned. I mean, that one's a little bit more tricky, right? Because if you're working 15 hours a day, when are you going to have time to socialize or to build those networks? And then it's about creating work environments that are imbued with social support and make time for socialization. We know that there's a lot of literature that work stress is higher when people don't have social support at work. And it's lower in environments where people do have the opportunity to build social relationships at work. So just creating a culture where we have time to talk to each other at work and have more support could be the solution here. Those are very good points.
Thank you guys for the discussion. It's clearly not, thanks for the discussion, it's clearly not simple. And that's why we raised it. It sounds to me like more than the generation of practitioners that I've experienced, you guys recognize that this is a big part of the experience that your patients have. And they're affected by it. And we have good data that shows that it affects their health. And you think about connectivity in terms of the psychological part, there are also physical parts in terms of our microbiome is better if you have a diverse community to live in. It's better if the diversity includes animals, interestingly. So we're going to have a talk about that as well. But again, just asking the question. I mean, it sounds to me like every one of you would naturally inquire, and that's the beginning. So I was kind of really pleased to hear how this discussion went. When we talk to older doctors, they don't really think this is part of the scope of practice. I'm just going to get labs and do an MRI, and that will tell me where to go with making these people well. And you heard that, being well has a lot of vulnerabilities socioeconomically. There are vulnerable populations out there that have less advantage to be well. And I would say connectivity is a marker in part of those things. So I appreciate your coming out. I want to thank Dr.
Yeah.
Hostinar. Let's give her a round of
Thank you.
We're going to be back next month with a talk about food as medicine and culinary health with Chef Sky, who happens to be right out under here. Our CIA trained chef, and then also with John Liu, your colleague, I think, in the second year class, who is a dietitian, and he's actually the formal advisor to the Office of Wellness Education. So keep your eyes open for that session. Thanks for coming, and I hope you have a good lunch and a good day. Thanks.
Thank you. Thanks, everybody.